Hi everyone, welcome to University of Louisville Health. We're at Jewish Hospital. My name is Dana Settles. I'm here today to help you learn how to set up for a TAVR. I'd like to teach you how our basic setup just to help you in your preparation. So we'll go ahead and get started. First, as we're all anesthesiologists, what I'd like you to do is set up your drugs on your back table. When we set up for TAVR, our plan is for MAC. But as an anesthesiologist, you always want to be prepared to intubate if you had to. So we always have propofol and sucks ready to go. In terms of our sedation protocol, what we usually do is we give our patients a little bit of Versed and a little bit of ketamine, meaning 1 to 2 of Versed and maybe 25 to 30 of ketamine. That way we can avoid narcotics, and that way we avoid respiratory depression. In TAVRs, you always need to be prepared to support their blood pressure, so we always have a syringe of Neo, a syringe of Epi ready to go. You can always throw calcium and vasopressin in there as well. After valve deployment, you want to make sure that you can get your blood pressure down. A lot of times after deployment, you have an increased cardiac output because you finally don't have aortic stenosis, so be prepared to fix that rebound hypertension and have cardine ready. You always have your antibiotics ready to go. A syringe of heparin. You will want to heparinize these patients once the proceduralists tell you. They're usually shooting for an ACT around 300, so make sure before you get started you get a baseline ACT, and then once you heparinize, you're going to have an ACT of about 300. If a patient's 70 kilos, you'll give about 7,000 of heparin, so it's about 100 units per kilo. And then finally at the end of the procedure, once the TAVR's in and everybody's ready to finish and move on and reverse the heparin, you'll have your protamine ready. So these are the drugs that I want you to have ready for when you do your TAVR. Next, I want to take you over to our ventilator. Again, at University of Louisville, our plan is to do these under MAC, but again, you always want to be prepared to convert to a general anesthetic if you need to. We have our Salter cannula ready so that we can give oxygen and also monitor our CO2. Again, keep in mind that you always have to be prepared to rescue, so we always have intubation equipment out and ready to go. Oral airways, anything you need to do to support your patient's ventilation. The next thing that I want you to have prepared is 2 pacing boxes. One is going to be for a backup rate. There's concern that during deployment you could always go into heart block. So rather than taking the time to unlock the pacer box, alter the settings, if you go into heart block, you can immediately turn on your backup rate. So I always have 1 pacer box ready as a backup in case during deployment you go into heart block. The other pacer box is for deployment. Now it depends on which device you're using. If you're using Medtronic, which is a self-expanding valve, your rate will be usually about 120 for deployment, anywhere between 120 and 140. Now, if you're doing an Edwards device and it's on a balloon, you need to pace faster, so you're going to be up around 180. Occasionally they'll want you to go a little bit faster, but traditionally for the balloon Edwards, you're going to be at 180. So always have those on and ready to go at all times. 1 pacer box is for deployment, 1 pacer box is for your backup. And again, vent is always ready to go. I told you a little bit about how we prepare for MAC. We give a little bit of Versed, a little bit of ketamine, and then once we come back here, we start them on some low-dose propofol. Rather than giving bumps and having your sedation waver up and down, a little bit of Versed, a little bit of ketamine, and then start your propofol at that constant low dose so you get a really nice steady state of sedation. So that's why we have propofol here. And then this is our pumps that we have set up and ready to go. You have your baseline carrier of IV fluid, and then you have Epi loaded and ready to go, and Levofed loaded and ready to go. This is to support the patient when they have wires across the valve, when they're getting ready to deploy the valve. A lot of times you need to support the patient. So this is our basic setup for TAVR at University of Louisville. A couple other tips that I have for you. One thing at the beginning of the procedure, again, always make sure you get your baseline ACT. I also always get a baseline ISTAT, which includes an ABG, hemoglobin, hematocrit, and all your electrolytes. And then I check one again at the end just to check on the patient, make sure everything looks okay. But basically this is our setup for TAVR at University of Louisville. I hope that this will help you and your team prepare for your next TAVR. Thank you.